Welcome to the ACE Hot Topic webinar titled Developing a High-Risk Breast Program. I'm Jen Wood, Meetings and Administrative Manager for ACE, and I have a few housekeeping items before we begin. We hope you can join us for one or both of the upcoming 2020 educational events. First up is the ACE Annual Meeting, scheduled for January 22nd to the 24th, 2020 in New Orleans. Registration for the annual meeting is open, and the Planning Committee has crafted a fantastic agenda. Secondly, please join us for the International Oncology Leadership Conference being held November 15th to the 17th, 2020 in Rome, Italy. Please visit the ACE website for additional information about either of these educational conferences. This webinar is being recorded and will be posted to the members-only section of the ACE website. We will be holding all questions until the end of the webinar. So if you think of anything during the presentation, please submit your questions through the question box on the GoToWebinar toolbar. It gives me great pleasure to introduce today's webinar speaker, Teresa Heckel. Teresa is an accomplished healthcare administrator with more than 30 years of progressively responsible experience in the oncology field. For the past 10 years, she has worked with large national health systems to assist them in cancer program development. Most recently, she served as the director of the National Oncology Service Line for Catholic Health Initiatives, leading the strategic development and implementation of cancer initiatives across their 50 cancer treatment facilities. As an oncology consultant, her work with large health systems is largely focused around developing clinical programs and creating tumor-specific cancer centers of excellence. She is currently leading the effort to develop high-risk women's programs across the Sarah Cannon HCA enterprise. She is the immediate past president of the Association of Cancer Executives, secretary of the board for the National Consortium of Breast Centers, and a board trustee for the National Accreditation Program for Breast Centers. We hope you enjoyed this webinar. Take it away, Teresa.
Thank you so much. So, Jen, I just want to do a really quick check, make sure you can hear me okay.
I sure can. You sound great.
Awesome. Awesome. Then I will assume that others can as well. And thanks, everyone. I'm really glad to be here and be sharing this information with you all today. We're going to just go ahead and jump right in here. So from my bio, you know that I'm not a clinician, I'm not a genetic expert, but I have had the privilege and the opportunity to work with Sarah Cannon. If you're not familiar with Sarah Cannon, it's the Cancer Institute arm of HCA. So the work that I've been doing there, as Jen mentioned, is I've been leading up the effort for developing high-risk women's programs across their enterprise. So I have a fair amount of experience in this space, again, although I'm not a clinician nor a genetics expert. So usually when I give these presentations, and I've done presentations on developing high-risk programs, and what I'm going to do is just kind of share with you some of the things that I've learned in leading this effort. But as I've been giving these presentations, the attendees have really represented kind of a big cross mix across programs who are maybe really fairly advanced and have more progressive programs than what I'm even working with right now. But they're interested in improving and learning from others. So, you know, they're interested in these particular presentations. But then there's also others who maybe have not even started down this path. So, you know, we might have everyone who's on this call. So I'm going to try and speak from a point that hopefully will produce some sort of nuggets for each of you, no matter where you're at. So for those of you who already have a program and are in the process of developing one, you know how complex and complicated a high-risk breast program can be. So I'm not going to be able to dive into all the details today, but what I wanted to do is just kind of share some of the practical things to consider as you're developing a program. Some of the pieces I'm going to share are really just kind of a primer around certain aspects, again, as there may be some of you are just starting the journey. But I really did feel that it would be helpful for you as you're building your business case. And since I'll have to keep it somewhat high level, I just want to let you know that if you all are interested in a deeper dive into developing a high-risk breast program, I'm going to be co-chairing a full-day pre-conference course on this particular topic at the National Consortium of Breast Centers conference that's It's in April, and it's always in Las Vegas. So if you're interested in that, it's obviously going to go into a greater detail. You can go to the NCBC website and sign up for that. So, the first thing as you're thinking about a program and really being able to articulate this to your executives as you're wanting to build that business case is really understanding why building a high-risk breast program is so incredibly important. And the reality, and as I got started really kind of diving into this work, I really had no idea how the magnitude of this particular problem. So we all know on this call, I'm sure, that breast cancer is the most common cancer in the U.S., and it's also the second leading cause of cancer deaths in women. But I think what many may not know before they really start digging in and developing a program is that we do have 1.2 million women in our country that have a history of breast or ovarian cancer that still need to be tested. And we have about 10.7 million women in our country that are unaffected, so don't have a history of breast or ovarian cancer, but still need to be tested. So over 90% of the women in our country that need to be tested, we have yet to identify. So it's really a high magnitude. And, let me just let you all know that I will be sharing the slides with Jen, so you'll have access to these slides after the webinar. But also part of the problem is around ownership, because really kind of who owns the development of a breast program and who owns this assessing of patients and identifying patients that are at risk. And part of the challenge for us in health systems is that this really isn't happening in the PCP offices because their time and the processes are really inadequate to support doing what they need to do to really adequately identify women that are of risk. And then if they do, PCPs are typically not comfortable with managing high risk. And all of these statistics come from a study that was done by Informed DNA a few years ago. So in that study, they found that only 35% of PCPs felt they could prescribe the right genetic test, and only 46% felt they could explain a genetic test result. And as that's getting more complicated, especially around panel testing, I'm sure that number would be a little bit lower at this point. And 30 to 50% of genetic tests that were ordered through this study, through that time frame that they looked at, they were actually inappropriate genetic tests for those particular patients. And I think it's also just really important that we're aware and we're able to share with this, again, as part of the magnitude of this problem, is that, women with genetic syndromes absolutely have a higher risk. And that specific level of risk is going to depend on the family history of breast cancer and the specific genes that are involved. But that for high-risk genes, that risk is up to 87%. So it's an extremely high risk. However, if we're able to identify these women, we're really, we have the opportunity really here to save lives. So if you look at cancer risk reduction, that when we identify women with these mutations, a mastectomy can reduce their risk by as much as 90% for breast cancer and as high as 96% for ovarian cancer. And there's also many benefits to the program. And again, as you're kind of thinking through the program and being able to, develop your business case, there's obvious benefits to the patients and providers, including certainly the opportunity to save lives and costs, because cancer cost avoidance is absolutely something that we need to consider. This is all about prevention. This is a prevention program. And patients and providers then become educated about risks and recommendations, and they become educated about what their specific risks are and being able to communicate that with their families. A program really helps to track and navigate patients along the continuum, and we're going to talk about the fragmentation and the challenges there are with tracking patients that are at high risk. The patient care gets coordinated with trained providers, and really it can instill the confidence in your referring physicians, that their patients, again, patients that they're typically not comfortable with managing, that they're getting, they have this multidisciplinary team that is providing comprehensive collaborative care. But there's also benefits to the health system, certainly, including increased volumes in supplemental screening. So you want to look at not only direct revenue from the services that you'll provide, but there's downstream revenue to consider as well. I think a really big benefit is that opportunity to reduce outmigration all along the continuum, and we're going to talk about that. I have on this slide here due to navigation and genetic counseling, because primarily that's that stopgap that keeps those patients from falling through the cracks along the continuum. It's going to help you differentiate your program in your market. I'm working with a facility right now, a program right now in a market, who said that even just exploring with their primary care physicians how they would feel about this and developing a high-risk breast program and dedicated program around this, they've already started to get increased referrals to their program. And this is it's a multi-specialty group that has the breast surgery and the medical oncology all there together. They're already getting more referrals for breast cancer patients since they've started to do this. And then certainly your ability to meet NAPBC and COC standards. But I think, we also need to be aware that there's a lot of barriers because there's a lot of challenges within a high-risk program. So women's reluctance to engage in high-risk screening. Oftentimes, I hear about some physicians, even though there's a number of physicians that maybe aren't comfortable with managing these patients, there may be physicians that are reluctant to support the program. They may feel that they're, afraid that they're going to lose control of their patients. Certainly, there are some protocols that may not always be covered by insurance. So, it's again part of that patient's reluctance because they may have, high deductibles, and so getting that MRI is just not, they don't feel is an option to them. We're going to talk a lot about IT a little bit later. I think ability to acquire genetic professionals, which we'll discuss. I did want to talk about lack of collaboration and lack of program ownership just a little bit because, like our lung nodule programs, and as you all are developing your lung CT screening programs and your lung nodule programs, those are collaborative programs that, have really forced us in oncology, who are typically driving these programs, to work hand in hand with imaging and to work hand in hand with other specialties as well, like, pulmonologists and thoracic surgeons in the case of a lung nodule and a lung program, but then, also other specialties across a breast program. So really, what is that program ownership going to look like? Who's going to drive that? That's a barrier that can absolutely happen. So as you're developing your program, you're really going to want to think about what the scope of services that you're going to be offering. When I worked with Sarah Cannon, we were really, really interested. We didn't want to just work on setting up screening in our breast imaging centers and really kind of leave it at that. Because again, the challenge that's happening is that there's so many women I've learned about that are getting identified as high risk at the breast imaging center. They're being sent back to their PCPs and nothing is happening. So obviously that is a huge tragedy. So we really looked at the entire continuum of care. So assessing women in the breast imaging center, and we started with the breast imaging center because the breast imaging center is the best place where you can capture the most women. Ideally, risk assessment, identification, and risk assessment starts in your PCP practice because women are typically not going to your breast imaging centers until the age of 40. And so we've missed all that opportunity for those women that are under 40. But you really have to develop out, the infrastructure for a full program before you really start reaching out and setting up these programs within your PC practices. So we needed something a little bit more controlled. So we started with that risk assessment at the time of the breast imaging, making sure that we had a seamless care and I'm sorry, I'm having a hard time finding the right word today. And that safety net across the entire continuum, because there's obviously opportunities for patients to fall through the cracks every step of the way. And it certainly happens, and we probably all have heard a lot of stories related to that. So figuring out your continuum of care is going to help you determine what your program model is going to look like, and then the services that you're going to offer. So let's talk a little bit just about identifying the high-risk patient. So you're really wanting to look at two separate clinical issues. So what I often find is that breast centers may be really just kind of utilizing some kind of quick red flags that are identifying patients that may be candidates for genetic counseling. But what's happening is then we're missing all of these women who may not be candidates for genetic counseling, but they are at high risk. They have a lifetime risk for developing breast cancer that we're missing out on helping to manage those patients and helping to mitigate those risks. So we want to identify women with increased 5-year and lifetime risk of breast cancer, but then also identify women for meeting criteria for genetic evaluation. And there are some women that will be both. And I'm sure you all know and understand that there are a large number of factors associated with an increased risk for breast cancer. And the reason why I share this slide with you is that as we think about doing risk assessment, there's a lot of data points that need to go into that risk assessment to determine what that particular patient's risk and the risk score is. So we're gonna talk about processes for that in just a moment. But as you think about your risk assessment, then you're going to need to identify what risk models and what guidelines you're going to use. And I really love this slide from Dr. Kevin Hughes out of Mass General, because I think this slide is a really great kind of graphic that depicts the different risk models and what it is that they're looking at. And so again, I've worked with programs where they've only used a Gale model. So they're missing a huge number of patients. So you can see that tiracusic, BRCA-PRO and tiracusic are pretty comprehensive over on that right side. And tiracusic also includes breast density now. So breast density, if you're not familiar with that, how high that risk is that women that have very dense breasts actually have a 4- to 6-fold increase in risk over a woman who has lesser dense breasts. So that's really important information to know as we're looking to manage our patients. And then understanding then kind of as you're looking at it and you're stratifying your patients according to risk, these are just the major categories of breast cancer risk. And again, with those that have that hereditary, have those genetic mutations, those are absolutely at the highest risk for breast cancer, but they're also at elevated risk for other cancers as well. So just kind of back to this, I wanted to then share as we worked in Sarah Cannon and we looked at, again, we wanted to have a comprehensive program. We wanted every woman that was coming through that was at increased risk, we wanted them to have the opportunity for us to identify that and be able to help to work with them to decrease their risk. So we utilize the tiracusic model. We recommend version 8 because it does take into account breast density. The Gale model for the 5-year risk to identify the women that will meet criteria for chemo prevention. And then also utilizing the NCCN guidelines, both for genetic counseling and for testing. So let's talk about technology, and I think this is the right time for us to do it because really as you think about that risk assessment process and really the high-risk program overall, I really do see that the lack of having an ability to leverage an IT solution is one of the biggest barriers and one of the reasons why many programs don't go down this road, because it is a heavily manual program in so many ways if you don't have an IT solution to help support the processes and to help support the workflow. So what I've put on here is just to look at the risk assessment and scoring process. So in gathering the patient's personal and family history, again, if you're going to do a comprehensive risk assessment, there's a lot of data points that you need to take into account. You need to capture and gather that data in order to do the risk assessment. So I just put an example of, a form that we developed and we have here for Sarah Cannon for our markets to use if they're only in a paper environment right now. But it's a lot for a patient to fill out, and they often don't have that information always with them right there because it includes family history. And then running the risk models, it requires someone from the team to take all that information from that patient's intake form and then feed that information into the various risk models online to get the scoring and stratification for that patient. And then once you have that, identifying, so now what do we do with that patient? What is appropriate for them in terms of their intervention based on what their risk is? And so, how many of us have time within the clinical setting to spend a lot of time utilizing NCCN guidelines and staying on top of what the appropriate interventions are? So, I only show this to really kind of demonstrate and highlight that it's a really manual, resource-intensive, error-prone process. But it doesn't just stop with a risk assessment. The slide I have up here is just kind of a really high level of, kind of a pathway through our high-risk breast program. What does that look like in terms of risk assessment and the breast imaging center, genetic counseling and testing, and then the high-risk clinic and managing that high-risk patient over time? And it's a lot. There's a lot of steps. There's a lot of opportunities for patients to, again, fall through those cracks. If you don't have an automated electronic tool for developing the pedigrees, your genetic counselors for developing those, then that's a lot of manual time that they're taking as well. And again, as we all know, with all these manual processes, it's obviously lots of opportunities for errors and lots of opportunities for patients to fall through the cracks. So I really recommend that you evaluate as part of your business case and the investments that you need to make in developing a program, a comprehensive cancer risk assessment and management solutions. And I'll tell you that in our experience and the research that we did, there's not a lot of them that are out there right now. There's a number of systems that can do portions throughout the continuum, but not that are comprehensive across the entire continuum. So if you look at a comprehensive solution, it's going to do a really great job in supporting, again, across the continuum. So the risk assessment, running the validated models, scoring and stratification, it's, some of that kind of clinical decision support that's built in that will help you around, what are the intervention recommendations based on that particular patient? How should we be managing them? It also supports that navigation of the patient across the continuum. Again, the genetic evaluation and testing with the pedigree mapping and the risk management and surveillance on the back end. But in addition, some of those other really manual things that we end up doing in the breast center, or in your genetic counselor's practice and office, like, composing a whole lot of letters to patients and providers and mailing those out and reminder phone calls and, all of those types of things. So I really just wanted to highlight that. I think it's really important to take a look at these because they will really help support your program. And I did want to share that at a minimum, if you don't make the investment for a comprehensive solution, at a minimum, you should ensure that whatever your MIS system is that you're using in your breast center is really supporting this program. So there's a lot of MIS systems out there, PenRad and MagView and MRS and Insight Omnicare and others. But, not necessarily all of their versions. So if you're not on the latest version, if you're not utilizing their latest, perhaps additional modules that you might have to purchase, etc., you may not be utilizing, you may not have that full functionality that you really need. So if that's the only IT support that you're going to have, the only system, really make sure that with your particular vendor that you have, really make sure that you're on the version and what that functionality is to help automate some of these processes for you. So then let's talk about navigating the high-risk patient. And again, as we just kind of look through that continuum of care, there's, again, lots and lots of opportunities for fragmentation because we're going across so many systems. So we identified within Sarah Cannon that one of the really critical resources that we felt we needed to be successful with a high-risk program and successful for our patients was the development of a breast imaging navigator coordinator. Most breast centers that I have worked with, and I've worked with lots of breast centers around the country, you know, have some type of a breast coordinator that has been managing perhaps the patients that are callbacks or going to have a biopsy, etc. But expanding that role to also then navigate the patients that are identified as high risk is really going to help make sure that there's that navigation from the breast imaging center and that environment to genetic counseling or to your high-risk clinic. And let me just say that these are breast imaging professionals or nurses, so an advanced RT, mammotech perhaps, or we've seen and have in many of our sites, we have RNs in there as well because they have an RN in the breast imaging center. But they really are a critical member of this multidisciplinary team. They're also the ones that is often those liaisons to your referring physicians and also to the other care coordinators. So they really are one of your, key kind of strategic relationship builders and absolutely champions for your high-risk breast program. And these folks can make a really huge impact, including increasing compliance for patients, both for imaging and things like biopsy follow-up. They're also one of your kind of, I think, I look at them as your best weapon against outmigration and leakage. Because again, as we know in oncology, and we probably all have navigators now that we use and we work with and utilize in oncology, is that those navigators that build those relationships with those patients and build those relationships with those referring practices are really key then for us not losing patients out of the system. Okay, so genetic counseling and testing considerations. For those, again, a little primary here. So I just want to talk about, here's the major components of that genetic counseling and testing process. Risk assessment, so they will typically do some additional kind of deeper diving and evaluation with the patient to make sure they've captured all the appropriate information for the patient to understand their risk. They do the pre-test counseling, so often that risk assessment is part of that pre-test counseling. And then testing, which includes selecting the most appropriate and cost-effective test for that patient, as well as working for that patient on identifying how they can get their family members in as well, and then ordering tests through high-quality labs. And then post-test counseling, that is part of the results disclosure. And what I found, every genetic counselor does this just a little bit different, but those are kind of the primary components, buckets of what the genetic counselors do. So as we're building our high-risk programs or, our genetic programs, we need to really think about what that provider model is. And this is a really busy slide, but what I really wanted, the message I really wanted to try and get across here is that not just anyone can do genetic counseling and testing. So if you are an NAPDC or COC accredited program, then you know that there are standards around the genetic professional that they have identified as being qualified in providing these care, this care for your patients. So it's a little bit challenging, and especially because we have a lack of genetic counselors for what the demand is right now. So we looked at what different resourcing options are because of that. So ideally, as we're building our programs, we're really looking at our high volume programs, and we would like to employ our genetic counselors because we feel that having them as integrated members of our team, we believe that having that opportunity for face-to-face counseling is important. We want those genetic counselors sitting at our tumor boards, at our conferences, really being an important part of that multidisciplinary team. But employment is not always possible. Again, there's high demand, the supply is low. There are many new training programs that are out there right now, but we've also seen a large number of genetic counselors kind of migrating over to the genetic labs as they've really been building out their businesses. So employment may not be an opportunity. So you can explore contracting locally. There may be genetic counselors, even at a competing facility that have capacity, and they would love to, have you contract. Or you may have independent genetic counselors within your market that you can contract locally. You can also contract remotely utilizing the genetic counselor extender model. And if you all are not familiar with this, just Google it, because there's some really good research that's out there right now, kind of on this model, which utilizes trained RNs or advanced practice nurses as kind of that extension of the genetic counselor that can help with some of those early upfront kind of assessment and counseling, and then pulling the remote genetic counselor in when really needed. Another opportunity is just contracting through genetic counseling staffing companies, and there's a number of these now. This has really grown. And then finally, there are, Myriad is the only one that I'm aware of that does provide teleeducation. So it is a way that you can utilize genetic counselors for teleeducation for your patients that have been identified for testing, but just be aware that it's not full genetic counseling. It's not going to provide you with a comprehensive program or service for those patients, and that in and of itself won't help you meet your accreditation standards. And for all of these, there's pros and cons of each. There's also different service delivery models. So again, as you kind of think about, how your genetic counselors might be providing this care for your patients, I just wanted to share with you kind of what this is looking like right now across the country. And this was last year's NSGC. They do their professional status survey every year. And you can see that the majority of genetic counselors are still providing face-to-face genetic counseling. About 60% of them are doing some genetic counseling via the phone. There's less that's doing via telemedicine, video, and kind of group genetic counseling sessions. Also wanted to just share with you a little bit around reimbursement, because reimbursement may influence your practitioner and your service delivery models. Reimbursement is not great for genetic counseling, but there is a code. However, just be aware that Medicare does not recognize currently, there's work that's being done, but it does not recognize genetic counselors as providers, nor does it recognize the genetic counseling CPT code, which is 96040. So I know many programs across the country that do not bill at all for genetic counseling. Some do a self-pay, kind of a small self-pay, and some do a mix for patients who do not have coverage, but then they bill commercial and insurance. So this will, again, that's a busy slide, but it'll be available for you in the slide deck. Also just want to make sure that you are aware that there are many states now that do require licensure for genetic counseling. So it's just an important consideration on a number of levels. One, in those licensed states, in some states now, those genetic counselors can write the genetic tests themselves. So, often there's a barrier with genetic counselors having to reach out and get orders from the referring physicians, which really kind of slows things down. So, so that may be an option that your genetic counselors are able to, write, just order the genetic tests themselves. If you're a large system and you're thinking about providing telegenetics, which I think is a real smart thing to do, as you're trying to get genetics into some of maybe your smaller rural facilities, again, you'll just need to make sure that your genetic counselors that are going to be providing care for a particular state are licensed. And then the referral model, so how genetic counselors get from, how patients who are candidates for genetic counseling get from either your breast imaging center or provider office, how they get there, how they're referred, can really influence and impact the number of patients that actually follow through with that. So this is a huge gap, a huge barrier as patients that have been identified at risk that end up really kind of not doing anything about that. But your referral model and how you do that can really greatly increase that. So as we look at these models, and this is Cancer IQ did an observational study looking at kind of their customer database, and what they found is that for patients that were seen and identified at the breast imaging center as being high risk, if they were just said someone's going to give you a call, or they were just referred back to their referring physician and said, go ahead and give a call if you want to schedule an appointment with our genetic counselor, less than 10% of those patients actually followed through and were seen by the genetic counselor. If patients were identified at the breast imaging center, so this point of care scheduling model, and that patient was, someone talked with them and they were scheduled before they left, for that appointment, they had a higher referral rate of patients that were actually seen. And then that point of care counseling, where patients actually had the opportunity to visit with a genetic counselor prior to leaving, they had the highest. I will say that I believe that your uptake of these patients can absolutely be much higher if you have things like your breast imaging navigator and your software that's going to kind of support the whole process through the patient, for the patient. So the next kind of bucket or step along that high-risk continuum is that high-risk management, and we're going to talk about high-risk kind of clinic considerations as well. So a couple different service delivery models as you think about developing a high-risk clinic, and one may be around kind of a more bricks and mortar, where you're identifying a space, ideally within your breast center, where your nurse practitioner is going to see patients, that may also have all of your support services right there to help support patients as well, like, access to smoking cessation, nutritional counseling, et cetera. And then, however, you might just have a virtual program where your nurse practitioner is embedded within one of your, perhaps your breast surgical practice. And so, referring the patient to that virtual high-risk clinic, again, ideally having that genetic counselor right there working hand in hand with that nurse practitioner, who is the one who's really managing the management and long-term surveillance of those patients. Having them integrated there together is ideal, even if it's a virtual program. So there's some factors that may influence which model that you may decide to take. And, some of those factors might be things like, what other high-risk services are currently being provided? And maybe there's a partnership potential. Looking at education and training of local providers. So, perhaps there's a practitioner within your community that kind of meets that COC and NAPBC requirements, and they're the practitioner that may do that. So that may be a more kind of virtual model. or you may need to recruit someone. A specialty physician, the specialty of your physician champion or your identified supervising physician may make an impact as well. If you have a nurse practitioner, who's going to be that supervising physician for that nurse practitioner, that may influence your clinic model. Certainly space and the availability of it, and then reimbursement as well. So your provider model, so who's going to be providing those services? Is it going to be a breast surgeon? Is it going to be a physician? Or is it going to be an advanced practice nurse? Just a couple of considerations around that. It's going to be obviously very dependent upon what you have available to you. What we have done within Sarah Cannon is we are really supporting that nurse practitioner run high-risk breast program, high-risk clinic model, as those nurse practitioners work under the license of a supervising physician. But we want those physicians, we want our breast surgeons seeing breast surgical patients. We want our breast medical oncologists seeing the cancer patients. So we just believe that it makes the most sense to utilize a trained nurse practitioner in this role, again, working hand in hand with referring and partner providers. And folks often ask, so what does the visit look like within that high-risk clinic? What actually is that nurse practitioner doing? So, they're also doing, depending on how patients are getting to them, they may also be doing the actual risk assessment on that patient and determining their score and stratification. They're going to, be providing the patient education about their particular risk and what their risk management options are. They'll make the appropriate referrals, whether that's for a patient now that has been identified as BRCA positive and needs a referral to a breast surgeon, et cetera. They will do the counseling with a patient, perhaps on lifestyle modification. So, other ways that those patients can reduce their risks. And typically, they'll also do a clinical breast exam, a lymph node exam. Some nurse practitioners do a larger system exam. So obviously, the E&M code that those nurse practitioners will be able to charge will be dependent upon those services that they're providing as part of that clinic visit. So kind of our last piece here is really, as you're thinking about the business case, I just wanted to share a little bit about the key investments. So, I kind of talked about them throughout the presentation here. Again, as we look across the continuum of the high-risk women's program, that breast imaging coordinator being, really important. Will you need to recruit a breast imaging coordinator? Do you have a breast imaging coordinator already currently in place that has the capacity that can now take on the additional role of navigating the high-risk patients? Do you have MRI capacity? Because you definitely will see, you should see, depending upon your volume, a pretty significant increase in your MRI volume. So do you have, the capacity on your MRI? Genetic counselors, so whether that's employing a genetic counselor, contracting remotely with a genetic counseling group, that's certainly going to be an investment that you're going to need to make. And then that FTE nurse practitioner and kind of what that model is going to look like for you all, or is it going to be a provider model kind of right out of the gate? As we were looking at building the pro forma for Sarah Cannon, we looked at the volume of patients that these particular key staff members could manage. And for the breast imaging coordinator, we really just we sat down and did an analysis. And again, every role is going to look a little bit different, but we developed a job description and what those key activities, those breast imaging coordinator, navigators, and I use them both interchangeably because they're used both interchangeably at many of our centers and maybe as yours. But that breast imaging coordinator, navigator if they're managing your callback patients, maybe perhaps talking with patients that are needing to come back for diagnostics, the patients who are coming in for biopsies, et cetera, and then also then managing the patients that are identified as high risk, because you will be identifying, up to 30% of your patients as being at increased risk. So that breast imaging coordinator, we did an analysis and identified that we felt that they could handle approximately 10,000 screening patients. So for a breast imaging center that was doing about 10,000 screening mammograms per year, you would need approximately 1 FTE for that. For your genetic counselors, we looked at, again, the National Society for Genetic Counseling, their study that they did, and without an IT solution to support those genetic counselors could handle a workload of, I believe it was in the 400s, and I apologize, I don't recall that. Hey, Jen, can you hear me?
Yes, I can hear you now.
Okay, that was really weird. I'm sorry, I don't know what happened. It just kind of went to like a busy signal, so I don't know if what happened, but I got dropped, but I apologize for that. So I'm not quite sure when I lost you all, Jen. Was I gone for a long time?
You were gone for, I would say, a little less than a minute.
Okay, good. Okay, so it wasn't bad. So, so genetic counselor, about 450-ish or so, without having that IT solution to support them, and maybe even double that if there in fact was that comprehensive IT solution to help support the work that the genetic counselors do. And then we did not do an analysis on nurse practitioners, just because we don't yet really have that great data within Sarah Cannon, and it's also highly, highly dependent upon what that nurse practitioner does. So many ways I've seen that those high-risk nurse practitioners have been utilized is in really kind of close conjunction with like the breast surgical practice. Often the supervising physician may be the breast surgeon. And those nurse practitioners really kind of become that breast program nurse practitioner that also sees the patients that have the benign breast disease. They manage those patients. They do the survivorship for the breast cancer patients, and they manage the high-risk patients. So there's a number of different things that those nurse practitioners do. So as you do your pro forma, it's really going to kind of depend on what those practitioners are going to do and what their volume is, and essentially the level of E&M codes they're going to be able to charge. And then finally, the investment of that IT solution to support across the continuum. So I have just kind of a really kind of high-level template of, a pro forma. As you all, excuse me, I need a little drink of water. As you all think about, putting your pro forma together for your program. So, what are those inputs in terms of your operating expenses? Or is there going to be equipment expenses? Are you going to need to purchase, do you not have the comprehensive diagnostic imaging technology that you need? Do you not have breast MRIs, et cetera? But for us, we looked primarily at the staffing. So that breast imaging coordinator, if you don't have them, the genetic counselor, if you don't have them, the nurse practitioner, if you don't have them. And then depending upon the size and volume of your patient, your program, or other support staff that you may have, you may need to consider some administrative support as well if there's not existing administrative support that could help with kind of along the whole trajectory of the program. And then that IT solution. And then on the right side, I just have some of the direct and downstream revenue that you will experience as part of a high-risk program. So, and it does, obviously, it does not include everything. It doesn't include the additional revenues that you'll get from ultrasounds or other screening or diagnostic or treatment procedures or the E&M visits for your nurse practitioner. So we did really kind of high level, trying to be a little bit more conservative. But as you think about your program, you're really going to want to develop your pro forma looking at including your downstream revenue as well. Because a high-risk program in and of itself isn't going to be a huge moneymaker for a health system. And truly, you may even be lucky to break even. But it is all that downstream revenue that you're going to generate, and that doesn't include the halo effect that a high-risk program is going to bring to you all in elevating your breast program overall, your breast imaging center overall, and the increase in awareness of your facility that you're going to enjoy from the community as well as from physicians. I also included for you as you look at your program is understanding, what are those key metrics that we want to track across the continuum so we understand how well we're performing. Not going to go over this at all, but you all will have this. We identified what our key measures were across the continuum, and then I have down there what the metrics are and the measures, and again, really happy to share that with you. So the last thing that I will leave you with, and we won't walk through this, but what those steps are for designing your program. And you may kind of go in different, in different order, but I tried to think through kind of from the very beginning to the end, what are some of those really, really key steps that you need to think about as you're developing program, and hopefully you all can utilize this as a bit of a checklist. So that is what I have. I always leave my high-risk presentations with this particular quote from Mary Claire King: to identify a woman as a carrier only after she develops cancer is a failure of cancer prevention. And it just brings us back on why this is so important. Thank you so much. So John, do we have any questions?
Thank you so much, Teresa. So if you have any questions for Teresa that you'd like to answer while on this webinar, please send them through the question box of the GoToWebinar toolbar. Otherwise, you can see Teresa's email is available on the screen for you if you have any individual questions that you would like to get in touch with her about. So we can give it a couple seconds to see if we have any questions. Well, Teresa, it looks like you gave all the attendees a lot to think about, and I'm sure that you're going to get some questions via email regarding your presentation.
Yeah, and absolutely happy to, and I hope you all were able to pull some pearls from this as you're developing or thinking about developing your programs. Again, don't hesitate to reach out to me. I'm happy to have any conversations with you all. So thanks for being on. I hope you have a wonderful holiday season, and we'll talk with you all next year. Bye-bye.